So let's start. Today is our last lecture in topographic anatomy. Today we will talk about topographic anatomy and operative surgery on liver and bile excretory ducts. So liver is a multifunctional organ and it performs very many functions in our body. As a digestive organ, it performs production of bile and storage and interconversion of nutrients. We know that via the portal vein, blood that is rich by nutrients which we absorbed from digestive tract, they come to the bile, they come to the liver, and they are absorbed here. For example, glucose, and glucose is stored in the liver in the form of glycogen. Yes, and fat is also stored in the liver. So the other function, it is detoxification, that is performed by Kupffer cells and phagocytosis. In the liver, synthesis of clotting factors is also accomplished, and in fetal period, it acts as a hemopoietic organ, so it participates in formation of blood cells. Topography of the liver should be known because enlargement of the liver will reflect any pathologies in it. So we know that the highest point of the liver is located in the fourth intercostal space in the right midclavicular line. And so inferior margin, the lowest point of the inferior margin is located in the 10th intercostal space in the anterior axillary line, and in the right midclavicular line, inferior margin crosses right costal arch. And after that, it goes upward, and at the cartilage of the left sixth rib, inferior margin again crosses costal arch, and inferior margin crosses superior margin. They meet each other in the fifth intercostal space between left parasternal and midclavicular lines. So we have to keep in mind that in people with different body types, location of the liver can vary slightly. For example, in hypersthenic people, liver can be located, inferior margin of the liver can be located slightly lower than costal arch, and it is considered to be normal. In normasthenic people, certainly depression of the inferior margin of the liver below the right costal arch, it allows us to suspect a pathology of the liver. So we won't repeat that the liver occupies nearly the whole epigastrium. Yes, it's obviously. And so syntopy of the liver, diaphragmatic surface is covered superiorly by the diaphragm. So anteriorly it is costal part of the diaphragm and interior wall of the abdomen, posteriorly thoracic vertebrae and abdominal part of the esophagus, aorta, right adrenal gland, and inferiorly there is cardiac part of stomach, superior part of duodenum, right kidney and adrenal gland, and hepatic flexure of the colon, and right part of transverse colon. Syntopy is very important for the surgeons. It allows to find the organ very fast after the surgical approach. Well, usually there are no problems with finding the liver, and liver helps us to get oriented in the abdominal cavity and find any other organs. We have to know, and we studied it when in the course of normal anatomy, fixation apparatus of the liver or ligaments of the liver. All of them are formed by peritoneum, by double layer of peritoneum. And we know that liver is located mesoperitoneally because there are places which are not covered by peritoneum, such as gallbladder fossa, and also Beer area or area nuda. It is between two coronary ligaments on the diaphragmatic surface of the liver. So there is falciform ligament, that connects the liver to the anterior abdominal wall, and posteriorly and laterally this falciform ligament continues to coronary ligaments first, and coronary ligaments at the sides, they end with right and left triangular ligaments. Falciform ligament inferiorly continues to round ligament of the liver. We remember, and this ligamentum teres hepatis, it is stretched between inferior margin of the liver and umbilicus. And we know that in fetal period, it contained umbilical vein that drained into portal vein. It carried oxygenated blood to the portal vein, and the most oxygenated blood in the fetal body, it came to the liver because liver performed a function of hematopoiesis, yes, formation of the blood cells. On the visceral surface, we can also see venous ligament. Well, here it is not quite visible. Okay, so there is venous ligament that is formed by venous duct. You remember that umbilical vein, when it came up to the liver, it was divided into two branches. The main branch drained into the portal vein, and the other branch, that is venous duct, it drained to inferior vena cava. And here, actually, we had to see here something different. So here we had to see lesser omentum. Lesser omentum is formed by two ligaments which are stretched between liver and the other organs. It is hepatogastric ligament that is stretched between liver and lesser curvature of stomach. And about this ligament we have already said at the previous lecture, and we said that at the lesser curvature of stomach, between the layers of hepatogastric ligament, right and left gastric artery pass, and we have to be aware about it. And the other ligament that is stretched between liver, visceral surface of the liver, and superior part of duodenum, it is hepatoduodenal ligament. And inside, between the layers of hepatoduodenal ligament, very important structures pass DVA, common bile duct, from the right, and then there is portal vein, and then proper hepatic artery. In proper hepatic artery, we can see that it gives inside the hepatoduodenal ligament right gastric artery that goes to the lesser curvature of stomach, and at the very end, before the porta hepatis, it is divided into two hepatic arteries, right and left hepatic arteries, which supply right and left lobes of the liver. So all of these ligaments should be dissected in case of hepatectomy. Removal of the liver. Actually, this surgery certainly is nearly never performed because people cannot live without a liver. And usually organ sparing surgeries are performed, about which we will talk later. So on the visceral surface of the liver, there are very many impressions of another organs due to a very interesting syncope. We actually have already said a few words about it. So there is, in the left lobe of the liver, there is a gastric impression for the cardiac part of the stomach, and there is also esophageal impression for abdominal part of the esophagus. We also can see, gallbladder fossa for the gallbladder, colic impression for the right or hepatic fracture of the colon, duodenal impression in the right lobe, renal impression for the right kidney, suprarenal impression, and so on. And we know, we have also studied it in the course of normal anatomy, that on the visceral surface of the liver, there are two sagittal grooves, right and left. So left sagittal grooves is formed by two grooves. Anterior one, it is groove for round ligament of the liver, and posterior one, it is fissure for venous ligament. And right sagittal groove is formed by gallbladder fossa anteriorly, and posteriorly it is groove for vena cava. And there is one more transverse groove that actually forms porta hepatis, a hilum of the liver, through which structures, tubular structures, not only tubular nerves also, they enter and leave parenchyma of the liver. So it's all of these things are clear. When we studied normal anatomy, we said that there are two surfaces, diaphragmatic and visceral, and that is absolutely right. And there are two margins, which are inferior and posterior, and still it is also right. And inferior one, sorry, is sharpened border, and posterior margin is rounded. And we are seeing that there are four lobes in the liver, which are right, left, caudate, and quadrate. And we also said that caudate and quadrate lobes actually belong to the right lobe anatomically, yes, because we said that falciform ligament separates the liver into two lobes. The larger one is right lobe, and the smaller one is the left lobe of the liver. That's what we studied in the course of normal anatomy. For surgeons, division is different. We will talk about it right now, because surgeons, they take into considerations blood supply and bile drainage from the liver, because these are crucial factors for removal of the part of the liver. We should remove a part of the organ in that way that won't disturb anyhow functioning of all the other parts of this organ. That's why surgically, liver is also divided into two lobes, but not in the same way how we said it in the course of normal anatomy. So you remember that mainly liver is supplied from two sources. It is proper hepatic artery, that is a branch of common hepatic artery from celiac trunk, and in different books it's written that proper hepatic artery gives the liver from 20 to 25% of blood, and also portal vein that brings to the liver 75 to 50% of blood. So portal vein is actually the main source of blood supply for the liver. In variant anatomy, in topographic anatomy, we'll also say at our practical classes that there are some additional hepatic arteries which can arise from right gastric artery, for example, to supply left lobe of the liver, or gastroduodenal artery to supply right lobe of the liver, but they are inconstant. So in all the people, there are proper hepatic artery and portal vein. And you know that before entering porta hepatis, both of these vessels, proper hepatic artery and portal vein, they are divided into two branches, right and left. Right and left. Here we can see it. And after that, each of them are divided into four more in such a way that allows us to divide the parenchyma of the liver in 8 segments. The same branching is specific for bile excretory ducts. So we remember that morphofunctional unit of the liver is hepatic lobule, and here in the hepatic lobule there are bile canaliculi first, which are divided into interlobular bile ducts, and then they become larger and larger until they reach segmental bile duct. And segmental bile ducts join each other and they form right and left hepatic ducts. And right and left hepatic ducts form at the porta hepatis common hepatic duct, where cystic duct from the gallbladder joins. So for branching of proper hepatic artery and portal vein and bile ducts, such a pattern is specific. Venous drainage from the liver goes through the hepatic veins, and they are usually from 3 to 6. Right hepatic, middle hepatic, and left hepatic. And we said as our normal anatomy classes, that hepatic veins, they do not live through porta hepatis. They live on the visceral surface of the liver. If to be more precise, they leave parenchyma of the liver in the fissure for inferior vena cava, and they drain directly to inferior vena cava. So venous drainage, direction of venous drainage and branching of venous drainage does not correspond to blood supply and outflow of the bile. Please memorize it. So, and according to branches of the proper hepatic artery and portal vein and bile ducts, Kuno in 1957 found 8 segments of the liver. So a segment of the liver is a pyramidal part of its parenchyma that corresponds to segmental leg. What that thing which I was showing you, this thing together, segmental artery and segmental vein and segmental bile duct, it is segmental leg. Segmental branch of portal vein, segmental branch of right or left hepatic artery, and segmental bile duct. Segments are arranged into the sectors. So totally, as I told you, 8 segments are distinguished. And according to branches of right and left hepatic artery, actually right lobe of the liver from surgical point of view is much smaller than right lobe of the liver from anatomical point of view. So surgeons consider that caudate and quadrate lobes of the liver, lobes of the liver belong to the left lobe. So in case of hemihepatectomy, we'll talk about it later, if we are planning to perform hemihepatectomy, so removal of the half of the liver, if we are planning to perform it from the left side, then we will also remove caudate and quadrate lobes. In case of right hemihepatectomy, we will remove that part of the liver that is located laterally from the right sagittal fissure. Laterally from the right sagittal fissure. So the following segments are distinguished. Caudate lobe, the first segment, then superolateral segment of the left lobe. Here we are moving clockwise, yes, a superolateral segment of the left lobe, then inferolateral segment of the left lobe, medial segment of the right lobe, which actually corresponds to the quadrate lobe, yes, then anterior-inferior segment of right lobe, posterior-inferior segment, here we are segment of right lobe, and posterior superior segment of right lobe, and anterior superior segment of right lobe that is actually invisible on the visceral surface of the liver, but we can see it on the diaphragmatic surface. Okay, and yes, segments are united into the sectors, which have very similar blood supply, and usually when we perform bilateral removal of 2 segments, we remove them by sectors. So there is a left lateral sector that corresponds to the second segment, and it is monosegmental. Left paramedian sector is found by 3rd and 4th segments, and right paramedian sector is found by 5th and 8th segment, here 5th and 8th segment, and right lateral sector includes 4th, 6th and 7th segments, and left dorsal sector corresponds to the first segment, so it is monosegmental. We have to know about first segment of the liver, or caudate lobe of the liver. Caudate lobe of the liver is supplied from both right and left branches of portal vein and hepatic artery, so it receives double blood supply. And venous blood also from the first segment of the liver outflows directly to inferior vena cava. So that's why caudate lobe of the liver suffers from any pathology, like from cirrhosis, for example, from ischemia, the last one. If, for example, there is a necrosis of right or left lobe of the liver due to a thrombosis of right and left hepatic arteries or right and left branches of portal vein, first segment of the liver doesn't suffer much because it has double blood supply. So first segment of the liver is special. Actually, functionally, we can say that we cannot say exactly to which lobe of the liver it belongs. It is somewhere in the middle, first segment of the, here you can see it again. So first segment of the liver or caudate lobe, it receives blood supply from both branches of proper hepatic artery and both branches of portal vein, and outflow of the bile goes to both right and left hepatic ducts. And outflow from the venous drainage from the first segment goes directly to inferior vena cava, not to one of the hepatic veins, directly to inferior vena cava. Okay, so porta hepatis is located at the visceral surface of the liver, and so portal vein, hepatic artery, and hepatic nerve plexus enter the liver through the porta hepatis, and lymphatic vessels and right and left hepatic ducts exit the liver, the porta hepatis. And you know that as any gland, liver is covered by connective tissue capsule, and it is named Glisson's capsule. And here in the porta hepatis, Glisson's or hepatic triad is located. It is portal vein, proper hepatic artery, and common bile duct. It is Glisson's triad. So the most common surgeries on the liver, these are resections. So resection, you know, it is partial removal. And usually resections of the liver are performed in case of injuries and tumors of the liver. Mainly two types of liver resection are distinguished, typical and atypical. So typical or anatomical resection, it's also known as European technique. It is a resection within the limits of the segment or sector or lobe of the liver. So it includes preliminary ligation of segmental or lobar or sectoral leg of corresponding segment or sector or lobe. So anatomical resection, when we follow boundaries of the segment. So we consider anatomic structure, we consider blood supply and outflow of the bile. So in case of typical resection, when we preliminary ligate vessels which supply this particular part of the liver, there is the main advantage, it is reduction of blood loss, because actually operations on the liver, they are always accompanied by a very big blood loss, like it can be 2 or 3 liters, and usually operations on the liver, they are always accompanied by blood transplantation, blood transfusion. Even if it is planned surgery, surgeons are always ready for blood transfusion. And if we perform typical resection of the liver, we can significantly reduce blood loss, but we cannot avoid it completely. Why? Because, as you remember, pattern of venous outflow does not correspond to pattern of blood supply. So even if we ligate branch of proper hepatic artery and branch of portal vein, we will not be able to ligate at the same time hepatic veins. And through the veins, blood loss, bleeding will anyway start, and we will have to stop it. We will have to perform hemostasis. Disadvantage of this type of resection, it is large size of the part of the liver that is removed. So it doesn't matter, despite the size of the pathology, it can be a very small tumor. We will have to remove the whole segment. So the whole segment or sector or lobe, they are removed independently from the size of a lesion. So that is disadvantage. So which types of typical resection of the liver are performed? Yes, first it is hemihepatectomy, like right hemihepatectomy, which includes 5th, 6th, 7th, and 8th sectors, yes, and left hemihepatectomy, 2nd, 3rd, 4th, and probably 1st if it is required, but it's not compulsory to remove the 1st segment because it has double blood supply, yes, we remember. So we also can perform lobectomy or removal of a sector according to the sectors, yes, right lateral, right paramedian, left paramedian sector. Segmentectomy, it is isolated removal of a segments from the 1st to the 6th. From the 1st to the 6th. So 7th and 8th segments are not removed separately as it disturbs venous drainage from 5th and 6th segments, because venous drainage passes through from the 5th and 6th segments passes through 7th and 8th segments, as we saw in previous pictures. And that's why if there is any pathology in 5th or 6th segments, we perform right paramedian or right lateral lobectomy. So we remove 2 segments, 6th together with the 7th or 5th together with the 8th. We never remove 7th and 8th segments separately. That's what you also have to memorize. So a typical resection of the liver, it is removal of the lesion within healthy tissues by clamp crush technique and ligation of consequent ligation of tubular structures. So we do not follow anatomic structure. Yes, we just know that there is a pathological focus, there is a lesion, we need to remove it, and certainly we do it within healthy tissues. And to crush, to make a dissection, we don't use scalpel in the liver. We take a clamp and we start to crush the tissues. And while crushing, we see that there are small vessels, but they are very numerous, which start bleeding. And we consequently ligate them. According to the shape of a typical resection, the following resections are distinguished. It can be marginal when we remove one margin. It can be cuneiform or V-shaped and transverse. So advantage, it is certainly tissue sparing technique. So we can remove very small part of the liver, unlike in typical resection when we had to remove the whole segment. Yes, and simplicity and quickness. So we don't need to spend in additional time to find a segmental leg, to ligate them. Like we just crush, we can even crush by fingers, actually, parenchyma of the liver. We crush and ligate. And yes, it can happen faster. But disadvantage, it is risk of severe bleeding and risk of necrosis of spared liver parts due to ligation of the vessels and bile ducts. So risk of severe bleeding is clear. Yes, we are trying to ligate, but we can fail, and we do not work very precisely. Yes, and yes, severe bleeding are possible. That's why in exhausted patients, a typical resection is not an operation of choice. In exhausted patients, in patients with a low level of hemoglobin, certainly we prefer typical resection of the liver because we need to save as much blood as possible. And yes, risk of necrosis, because we actually work blindly. Yes, we see something is bleeding, we ligate it. Probably that thing that is bleeding, that it carried blood to another segment, and we are not, but we didn't notice it. Yes, and risk of necrosis is higher if to compare it with typical resection of the liver. Still, both techniques exist, and what is preferable in this particular patient, it's up to the surgeon. Yes, every time he has to decide what will he choose for this particular patient. So here you can see wedge-shaped resection of the liver and marginal resection and transverse resection here. Yes, here we can see transverse resection of the liver when we cut the liver transversely. Okay, so which surgical approaches are used to the liver and bile excretory ducts. So Courvoisier-Kocher approach, it's here, number 1, you can see, it is just an incision parallel to the costal arch. Further's approach, number 2, like we start from the xiphoid process and we move along the midline 3 to 4 centimeters lower, and then after 3 to 4 centimeters we turn and we move parallel to the costal arch. Rio Branco approach, it's here, number 3, or in English literature it is named reverse L-shaped incision. So it is in case of complicated surgery and for the beginning surgeons which need a very wide approach, for the beginners to see everything, it can be used. In oncosurgery, it is very widely used, this approach. Like first, dissection along the midline up to the umbilicus, and then we turn and then we move upward to the costal arch. Superior median laparotomy can also be used. You remember, yes, superior median laparotomy, it is an incision along the midline from the xiphoid process up to the umbilicus, and if we need, we should surround the umbilicus from the left side, because from the right side there is round ligament of the liver. So these are the main approaches for the open surgery on the liver and bile excretory ducts. When we had a lecture about laparoscopy, we said that, for example, for cholecystectomy, gold standard now is laparoscopic approach. So it is also used, even in experienced surgeons can perform laparoscopic surgeries on the liver, but beginners certainly should start from laparotomy first. Okay. So during surgeries, as I told you, liver has a very rich blood supply and it has very many vessels, and blood loss during surgeries on the liver is very big, and that's why we have to know how to perform bleeding arrest or hemostasis during surgeries in the liver. So temporary methods, it is Pringle maneuver, and also bimanual compression of liver parenchyma. So bimanual compression of liver parenchyma, like just to compress it by 2 hands, is used when we have a local bleeding and we know where to press to stop it, yes? But if there is a bleeding from everywhere, like blood is everywhere, we don't see anything in the operation filled by but blood, then we have to use Pringle maneuver. What is it? It is a compression, finger compression first, because like fingers are the first things that we can find. Compression of the structures, I mean portal vein and proper hepatic artery inside the hepatoduodenal ligament. So first we compress by fingers, and we certainly, like, we are shocked, but we can find a clamp and we can apply a clamp onto the structures in the hepatoduodenal ligament. And as it is, these are nearly only sources of blood supply, bleeding will stop. But certainly it cannot last long. It can last long, but it cannot last eternally. So there are some limitations. Continuous compression should last not longer than 1 hour. Like, you can apply this clamp, but after 1 hour of surgery, you should remember that you should take it off for at least a short time, yes. And intermittent compression, so for 10 minutes you will compress and then 5 minutes pause. It can last 300 minutes for healthy liver and 200 minutes in case of a cirrhotic liver, in case of a liver that is damaged by cirrhosis. So surgeries on the liver last very long. Surgeries of the liver are very complicated. So that's why 300 minutes, it's not it's 5 hours, but for surgery on the liver, it's not very long. We can also perform selective Pringle maneuver. It is a compression of branches of proper hepatic artery and portal vein. So we can move a little bit higher, but it requires then some separation, some yes, removal of tissues in the hepatoduodenal ligament, or maybe we will even have to enter porta hepatis, and we can compress right or left branches of proper hepatic artery and portal vein. This selective Pringle maneuver actually doesn't have time limitation. So if you use selective Pringle maneuver, you can compress as long as you need without any serious complications. So yes, in case of urgent surgeries, this method is used, but even in case of pre-planned surgeries, if you just want to prevent blood loss, you can also use Pringle maneuver in case of surgeries on the liver. Final methods of hemostasis in the liver, they include application of hepatic suture, cauterization, application of fibrinic glue, tamponade of the wound by fibrinic sponge, tamponade of the wound by greater omentum, and tamponade of the wound by an otter muscle. Actually, at the lecture of surgeries of the vessels, we were talking about final methods of hemostasis. Everything is clear for you, yes? So if we are talking about hepatic sutures, not only hepatic, but sutures on all the parenchymal organs, the same requirements. They can be applied in the suture of the spleen, for example. What should we know? What are the requirements? Suture should be directed perpendicularly to the vessels, to ligate them, yes? For the arrest of bleeding from parenchymal organs, it's recommended to perform a tamponade of the wound with an omentum, muscle, or use hemostatic sponges. Sutures shouldn't cut the parenchyma, and to avoid it, yes, we should use sutures should be rather wide, because if we make a suture very close to the wound, to the margin of the wound, they will certainly definitely cut the parenchyma. So while tying the threads, parenchyma of the organ should be compressed equally along the line of the suture. So tension should be equal. For passage of the thread, a needle with a rounded tip is used that doesn't cut but pushes tissues apart. So it is like piercing needle, but even this piercing needle should be with a rounded tip, very soft. It does not cut anything. It just should separate the tissues for the needle to pass. We have said about it, yes, also at the lecture about surgeries on the vessels. Like if such a needle meets on its way vessel, for example, or nerve, it won't piece it. It will move it away and continue its own movement, yes? And so number of pieces should be minimal. The less, the better, in case of suture of parenchymal organs. So what are the main sutures, types of sutures, which are used on surgeries of the liver? So Kuznetsov-Pensky suture. So Kuznetsov and Pensky, they are certainly great Russian surgeons, and we use this suture widely. So I'm sure that in your countries it is also used, but probably it has another name. But still, so look, how to apply it. So you take two threads at the same time, and you make simple continuous suture at the margin of the wound. And it's even better for you not to confuse the threads, to use threads of different color. And so after that, we take scissors and we cut one thread from one side and another thread from the other side. And after that, we tie knots, yes? So when because we took two threads at the same time, number of pieces was twice less than it might be, yes? And because knots are from both sides, we will provide very good hemostasis. So what are the advantages? Actually, I have told you. So all the tissues are sutured and ligated, and all the ducts and vessels are caught by ligature, and such type of suture provides secure hemostasis. Disadvantages are the following. So like threads can be tangled while tying, because yes, it's very easy to confuse threads, especially when they are of the same color. Yes, risk of unequal tension of knots. So this risk is always present when you use interrupted suture. When you use continuous, actually you are nearly sure that every step, every stitch will have the same tension, because finally there will be just one knot. Yes, and here in case of interrupted sutures, because each stitch has its own knot, yes, tension can be different. And parenchyma can be cut by threads, is also possible. The other type of suture is Giordano suture. In this case, we also take two threads, and we this thread simultaneously by one needle we conduct from one margin of the wound to another margin of the wound. After that, we divide them and we tie from both, like we take adjacent threads and we tie them from both sides. So what you can see with this interrupted line, it is the result. Yes. So advantage is that technique is simpler. Yes. And also all the sutures, all the tissues are sutured and ligated. And the same disadvantage that there is risk of unequal tension of knots, because again the suture is interrupted, yes, and cutting of parenchyma by threads. So yes, this is Giordano suture. Opel suture. You are taking just one thread and you are making like a normal nodular suture. It is very easy to perform and it's rather tight and hermetic, but because we take only one thread, so we make twice more pieces to provide the same hemostasis, to make the same suture as in case of Giordano and Kuznetsov-Pensky suture. So this is a disadvantage of this type, Opel suture. So these three are the main which you have to know. Actually, you have to know much more, but at least for the exam, you have to remember these three. Okay. So criterion of efficacy of liver suture is an absence of bleeding and intrahepatic hematoma 15 minutes after the application of suture. So we apply the suture and we are waiting. Well, certainly we are not just standing and praying, we are doing something else. But after 15 minutes, we check the suture again. And if there is not a bleeding, and if there is not hematoma in the region of the suture, means suture is good. What are the contraindications for liver sutures? It is deep injury when bottom of the wound is not visible. Passage of the thread through the wound, through the bottom of the wound in any parenchymal organ is crucial, because, once again, I'm telling you, numerous vessels are present, yes, in the parenchyma of the liver as well as in the spleen. If we make if we leave a cavity in the bottom of the wound, then certainly hematoma will be formed, and hematoma will be enlarged all the time, and it will finally cut the threads, and imbibition of tissues will take place, and it will have very serious consequences. Yes, so if you do not see the bottom of the wound, you shouldn't apply liver suture. In case if you don't see the bottom of the wound, you should first perform resection, maybe marginal, to see bottom. And only if you see bottom, you will apply liver suture. Intensive bleeding from the wound is also a contraindication. You should stop bleeding first, or again, maybe perform resection and then apply a suture. Presence of non-viable parts of parenchyma 5 to 6 centimeters laterally from the wound margins is another indication for resection. All the non-viable tissues should be removed. So resection should be performed, and then after that, liver suture should be applied. Okay, that's about surgeries on the liver. Gallbladder, vesica biliaris. Yes, you also remember about functions of the gallbladder. You know that it stores bile and concentrates it, and you know in course of normal anatomy we said that bile that is produced in the liver, it leaves liver through right and left hepatic ducts. We join common hepatic duct, and from common hepatic duct, if there is no chyme in the duodenum, or this sphincter is closed, yes, blood will go to, bile will go to the gallbladder and it will be stored there. Now we can say that actually there are additional myrice ductiles which are located in the gallbladder fossa, and through these myrice ductiles direct entrance of the bile to the gallbladder also takes place. We should consider them when we perform cholecystectomy, surgery of the removal of the gallbladder. Okay. So it is located in the gallbladder fossa. Yes, it's clear, and there are three parts: fundus, body, and neck. Is absolutely simple. And from the neck, cystic duct starts, which joins common hepatic duct, and they form common bile ducts. These are bile excretory ducts. So common bile duct joins later very close to the descending part of duodenum. It joins main pancreatic duct. They form hepatopancreatic ampulla, and at the vetus papilla or major papilla of duodenum, they open into the duodenum. Now we can say that actually there are many more sphincters. Sphincters are present in every part where one or another part of, like when ducts join. So yes, there is a sphincter of Oddi. It is sphincter of hepatopancreatic ampulla that is closed until chyme enters the duodenum. There is sphincter of main pancreatic duct. There is sphincter of Boyden, that is sphincter of common bile duct. There are another sphincters of cystic duct and common hepatic duct as well. So they are very many. When we perform surgeries on the gallbladder, we should know such a triangle, that is a cystohepatic triangle or Calot triangle. For surgeons, it is very crucial to find it, and they use it to find cystic artery. So Calot triangle is bounded by common hepatic duct on the left side and cystic duct on the right side, and in different books it is given, different information is given. Somewhere it's written that it is a visceral surface of the liver superiorly. Somewhere it is written that the superiorly there is right hepatic artery. This is right hepatic artery, yes, but content of the Calot triangle is a cystic artery. So to find cystic artery, and we in any case should find cystic artery if we're planning removal of a gallbladder, yes, we should use Calot triangle. So which surgeries are performed on the gallbladder? So mainly, yes, it doesn't matter which surgery is performed. Position of the patient is always supine with a roller under the back at the level of the 11th and 12th thoracic vertebra. So it allows us to approach gallbladder to the anterior abdominal wall if we put a roller here, yes, under the back of the patient. So surgical approaches are the same, like approaches to the liver. It is Federer's approach, Courvoisier-Kocher approach. There is also Sprengel approach. And yes, in non-complicated cases, nowadays, mainly laparoscopic approach is used for surgeries on the gallbladder. So the easiest, the simplest surgery, it is cholecystotomy. It's obviously, yes, cholecystite is gallbladder, tomy means dissection. So usually cholecystotomy is performed in case of calculous cholecystitis, so in case of gallbladder stones, when we need to remove this stone, when it is big, and we need to remove it, and it is single. Yes, if there are numerous gallbladder stones, usually we perform cholecystectomy. So approach oblique laparotomy by Fedorov in most cases. So we perform exposure of the gallbladder and application of purse string suture onto the fundus region. So the same as the previous lecture, we were discussing gastrotomy and gastrostomy. Actually, technique is very similar. Yes, we perform purse string suture preventively. Yes, like we apply it, but we do not tie a knot. Yes, we do not tie it. Yes, and then in the center of this purse string suture, we perform puncture of a gallbladder, and we evacuate all the bile from it. Why do we evacuate all the bile? Because we shouldn't allow the bile get into peritoneal cavity, because just like gastric juice, it is very irritating liquid. Like it, we will cause enzymatic peritonitis, like it's very severe complication. Yes. And so after we are sure that there is no bile in the gallbladder, we dissect gallbladder and extract stones. And then we tie a purse string suture. So very simple procedure. If we need to provide drainage of the bile from the gallbladder, then we apply cholecystostomy. So we start the same, like cholecystotomy can be used as a separated surgery for removal of gallbladder stones, for example, and just as a surgical approach, like in case of cholecystostomy. Yes, so we do the same. We perform oblique laparotomy by Fedorov, and then we perform exposure of gallbladder and apply purse string suture onto the fundus region. Then we dissect gallbladder, extract stones if they are present, yes, and then we insert drainage tube into the lumen of gallbladder. Here you can see it. And then we tie a purse string suture around the drainage tube. So what the other thing that we have to do, just like in gastrostomy case, yes, we should perform cholecystopexy. It is suturing of the gallbladder with the drainage tube to the parietal peritoneum. Why do we need it? To prevent a leakage of the bile between drainage tube and this wall of the gallbladder. If, for example, there is a very severe adhesive process and there is no way to hang a gallbladder to the parietal peritoneum, then we take a sterile gauze tissue, yes, and we surround this drainage tube by this gauze tissue, and then we fix this drainage tube to the anterior abdominal wall. But we should do our best to fix gallbladder to the parietal peritoneum. That would be better. Okay. So cholecystectomy, it is surgery of the removal of gallbladder. We perform it in case of numerous gallbladder stones when cholecystotomy is not performed, and tumors of a gallbladder. And mainly there are two methods: retrograde cholecystectomy from the neck and antegrade cholecystectomy from the fundus. So retrograde, it is in relation to the outflow of the bile. So we know that blood flows from the head, from the fundus to the neck. That's why when we start from the neck to the fundus, it is retrograde. And antegrade, when our actions, the sequence of our actions coincides with the outflow of the bile, so from the fundus to the neck. And so the main stage of both methods is an exposure and ligation of cystic artery and cystic duct at the region of hepatoduodenal ligament. So what are the stages of retrograde? Mainly, if there are no complications, if there are no obstacles to perform, we perform retrograde cholecystectomy. So approach is an oblique laparotomy by Fedorov, or laparoscopic approach is very widely used, yes. So when we do it, when we perform revision of the Winslow foramen, gallbladder, cystic, and common bile ducts. So then we apply ligatures or clips onto the cystic duct. So first ligature or clips is applied 0.5 centimeters distally from a junction of cystic and common hepatic ducts. So here you can see application of the first ligature. So it is obviously, yes, that to find cystic duct, we certainly should dissect anterior layer of hepatoduodenal ligament. And so we remember that common bile duct occupies the most lateral position. And so we find common bile duct and we move superiorly until we find cystic duct that arises from common bile duct. And when we find it, we apply the first ligature. Why it must be 5 millimeters only? Because ligation of cystic duct closer to place of junction may cause narrowing of common bile duct or slipping of the ligature. So if it will be very close to common bile duct, then by our ligature we can perform constriction, or also ligature can slip out and there will be leakage of bile in postoperative period. And if we form a longer stump, like it can, if it is more than 5 millimeters, then it may cause a development of post-cholecystectomic syndrome. What is it? Post-cholecystectomic syndrome. Bile, when sphincters are closed, will still try to enter gallbladder. That is actually not, yes. And if stump is long, and if bile will all the time apply pressure, then with the time the stump will become dilated, and patient will always feel like tenderness, yes, in this right hypochondric region, like feeling of expansion, feeling that something tries to expand his hollow organ, yes. And with the time, like a neo gallbladder is formed, and because it is like a dead end, gallbladder stones can be even formed inside this neo gallbladder, and this is post-cholecystectomic syndrome. It is not good. We should try to avoid it. So after that, we apply second ligature or clip onto the cystic duct 0.5 centimeters distally, so higher from the first ligature, so towards the gallbladder. And we will dissect cystic duct between two ligatures. So in case if we apply clips, that is, for example, laparoscopically, we usually apply clips. There is clip applier, special instrument. So in case of application of metallic clips, we use 3 clips. 2 should stay in the body, so 2 should be closer to the common bile duct, and 1 onto the part that is removed. Because we should no way allow leakage of bile into the peritoneal cavity. Once again, I'm telling you. What is very important, that cauterization, so electric energy, is never used onto the bile ducts to prevent postoperative necrosis and leakage of bile. So what is a mechanism of action of cauterization? It is actually nothing but burn, yes? And we know that burns, they have like late complications. Like first we formed like, what is it? Like covering as a burn, and it closed and there is no leakage. But with the time, this covering will be necrotized and it will fall out, yes? And then we will deal with leakage of bile. And because bile has this cholic acids and like has such an irritative composition, it will even speed up this, like it will contribute to the leakage of bile in postoperative period. That's why we never apply cauterization onto bile ducts. We can cauterize vessels, it is allowed and it is widely used, but we never apply cauterization on the bile duct, so please remember it. It is very important. So then, after we dissected bile duct, sorry, cystic duct, yes, then we perform exposure and ligation of cystic artery within a colored triangle. So here, yes, we apply 2 ligatures and we dissect cystic artery between 2 ligatures. And here we should remember that if we confuse cystic artery and right hepatic artery, and it is quite possible, so then we will deal with the necrosis of right lobe of the liver, and it's very serious complication. So then within a few days we will also have to perform right hemihepatectomy, yes? Okay. And so after that, we dissect visceral peritoneum around the gallbladder and separate gallbladder from its fossa. And when we separate it, we should remember that there are these additional bile ductiles which drain directly to the gallbladder. And we also shouldn't cauterize them. We should ligate them wherever it is possible. Okay, and so then we perform peritonization, so with huge peritoneum layers above the gallbladder fossa. We perform peritonization to reduce formation of adhesions. Place of a stump of a gallbladder shouldn't be covered by peritoneum. So what are the advantages of retrograde cholecystectomy? Gallbladder is removed with its content. So such a method excludes outflow of bile and exit of stones from the bladder during surgery, because the very first thing what we are doing in this case, we ligate cystic duct. So we remove the filled gallbladder, yes, outflow of bile, for example, it is especially not indicated in case of cholecystitis, when there is pus, for example, in the bile, yes, there is inflammation, or when there are stones which can, during surgery, go out from the gallbladder and stuck somewhere in bile excretory ducts, yes, and require repeated surgery for removal of this. So in case of retrograde cholecystectomy, such complications are excluded, certainly if we are good surgeons. If we are not good surgeons, everything is possible. And such a method provides a revision of hepatic ducts and cystic artery in a nearly dry wound. So the first thing what we are doing, we try to find cystic duct and cystic artery. So it is the very beginning of surgery, and the wound is, yes, wound is still dry. Antegrade cholecystectomy is performed when there is an adhesive process, when we cannot reach cystic duct. Visualization of cystic duct and cystic artery is impaired, and then we start from the fundus. It is antegrade cholecystectomy. So in case of cholelithiasis, also tumors of the gallbladder, in a case of adhesions at the neck region. So it is not an operation of choice. Operation of choice is always retrograde cholecystectomy. Whenever it is possible, we should perform retrograde. But if it is impossible, then, but we anyway should perform a surgery, we perform antegrade cholecystectomy. So advantages, yes. Surgeon approaches hilum of the gallbladder, having an opportunity to identify its elements precisely. So if we go from the fundus to the neck, then from the neck we can follow and we can exactly find cystic duct. So we will not confuse it with common bile duct, for example. We will not ligate common bile duct, and we will exactly find cystic artery. We will not confuse it with right hepatic, because we are absolutely sure that it starts from the gallbladder, and we will follow it. Yes. Disadvantages are the following: that during a surgery, bile and stones can exit from gallbladder and block bile excretory ducts and infect them in case of purulent process. And also increased blood loss, as cystic artery is ligated only after separation of the gallbladder. So these are two disadvantages. So approach is the same: oblique laparotomy by Fedorov, and then we perform dissection of visceral peritoneum around the gallbladder and its separation from gallbladder fossa in a direction towards cystic duct. Then we suture peritoneum above gallbladder fossa. Then we ligate and dissect cystic artery at the neck of gallbladder, and we ligate and dissect cystic duct 0.5 centimeters distally from the common bile duct. And certainly, in both cases, we shouldn't forget about the veins, because venous outflow. Gallbladder also has venous outflow. But first we ligate artery. Only after that we ligate vein to decrease blood loss in any surgery. Yes, we perform the same. So, yes, and actually that is all. So what are the possible complications of cholecystectomy? It can be avulsion or injury of a cystic artery before the ligation, and then we will deal with bleeding, yes. Avulsion or injury of a cystic duct, and then we will deal with the leakage of bile and probably peritonitis in future. Anyway, bile will lacerate a peritoneum, yes, and there will be peritonitis, yes, anyway, and adhesions will be definitely formed. Injury of a hepatic artery or portal vein, and then we will deal with a very severe bleeding, and injury of any other hepatic bile ducts, formation of a long stump of a cystic duct, and then in future, like there will be no early postoperative complications, but in the future we will get post-cholecystectomic syndrome, and dissection of a duodenum or colon, just due to the anatomic proximity. And if we notice it in time, then we will just stitch it, and if we do not notice it in time, then we will have again peritonitis, and it will require re-laparotomy, repeated surgery, and so it is also a very serious complication. So that is all I wanted to tell you for today. Actually, that is all I wanted to tell you in the course of topographic anatomy and operative surgery. Do you have any questions?